Good morning, everyone. Thank you for having me today. I'm going to talk about, cover the topic of cytomegalovirus, or CMV, and mainly transplant and hematopoietic cell transplantation. These are my disclosures, and this is the background or the outline of my talk. I'm going to start first with some background about CMV in immunocompromised patients. Then talk about the burden of this infection. There is new strategy to try to predict the infection, but also new drugs either already approved or under development to prevent or treat this infection. First, a quick word about herpes viruses in general. The problem with herpes viruses, it can cause latent infection, meaning after we get exposed and get the infection, these viruses stay dormant in our body forever. And this has to do with the viral genome, which can stay in the target cells. Any stimuli, like decrease in our immune system, or sometimes only stress can trigger these viruses. And then we get either reactivation, either in the blood, or sometimes can cause end organ disease. And we rely on our T cells, cytotoxic T cell, to keep it in check, and other pathway as well. CMV, or cytomegalovirus, we have big respect for this virus. It is pretty dangerous. We know by itself can cause lots of problems, and I'm going to talk about it later. It can stay dormant like other herpes viruses forever, and it's indestructible. So even if we get rid of it one time, it can happen again and again, especially if we still immunosuppressed in immunocompromised patient. And also, it takes about almost up to 40% of our CD8 and CD4 T cells to keep CMV in check, or they have a pretty specific T cells to control CMV infection. So big area of our immune system, it's working to control this kind of virus in someone who's immunocompromised. So let's talk about specifically about CMV itself in mainly our stem cell transplant patients. It is one of the most common infections that happen after transplant. If you think about it, most of us, around, at least in the US, up to 70 or 80% of the population has already been exposed to CMV. It's in latent phase. So if they go into transplant or any kind of immunosuppression, there is a chance between 50 and 80% for this virus to reactivate after transplant. So the incidence could be as low as 36%, but as high as 80%. So which infection usually happen this commonly? It's probably this one of the most common infection, at least viral, if not even between viruses and bacterial infection. The problem with CMV is not only the reactivation in the blood, but we worry about end organ disease. What I mean for that is this virus can reactivate and they can progress and can affect the lungs, can affect the GI tract. Sometimes the eyes is very rare, except in HIV population, but other organs as well. And that when this happens, we know that the mortality is very high. So our job is to try to prevent progression from reactivation up to end organ. But also, if we can prevent reactivation, this will be great, because it's all about prevention. That's what we try to accomplish in the infectious disease world. And the incidence actually over the past probably 15 to 20 years, the incidence of CMV and organ disease went down because, we have a new strategy, and I will talk about it later. We're trying to prevent CMV and organ disease. But we find out it's not enough only to prevent end organ disease. It's good to prevent also reactivation, and I will show you some new data on that. Okay, so CMV can cause direct effect, which is the end organ disease, from pneumonia to GI disease, hepatitis, maybe retinitis. We worry also about the indirect effect of this CMV. This virus is an immunomodulator virus. It can plays tricks on our immune system. By itself, CMV can make us more immunosuppressed, especially in patients after transplant. There have been some association between CMV and solid organ rejection, maybe graft versus host disease, but also superimposed fungal and bacterial infection after reactivation. It's not uncommon, and it could be because of the virus itself causing this immunosuppression, but also the treatment of this infection can, especially with ganciclovir, it can cause myelotoxicities and degrade the immune system of our patient, causing more problem with bacterial as well as fungal infection. We need to look for risk factors for CMV infection or disease. And some risk factors differ from the period of transplant up to 1 year or more after transplant. Early on, after the conditioning regimen, within 1 month from conditioning regimen, the risk factors are usually related to the chemo that we give to patients before they get transplanted. And the reason is sometimes we use T-cell depleted agents. And when you get rid of the T cells, then you put patient at risk for reactivation for this infection. So the conditioning regimen play a big role in this kind of, in this period. The type of transplant as well, which also can dictate the conditioning regimen. The highest risk transplant is usually haploidentical or cord blood transplant, because they can get T-cell depleted. With cord, they can get ETG or ex vivo depletion. In haploidentical, usually they get also, now it's very common to get post-cy or post-transplant cyclophosphamide, make them more T-cell depleted. So they're going to be at risk not only for CMV, but other viral infections as well. Between day 30 and day 100, you start having more the graft versus host disease, which is not uncommon after transplant. And then the treatment of GVHD put them at risk for CMV infection and other type of infection. And after day 100, if they're not doing well because they had GVHD, they are on steroids, or if they had already CMV infection, these are all risk factors for late CMV disease or late CMV infection after day 100 from transplant. What do we do to prevent this infection or to at least decrease the incidence of CMV disease? We started a long time ago, more than 20 years ago, using what we call prophylaxis, right? So you have a drug that you give it from the time of engraftment up to day 100. This is the high-risk period for our patient for CMV infection. So when you do that, you give it to all patients who are at risk and try to prevent 60 or 70% of this reactivation. But this strategy, it's not followed anymore. And the reason is the drug that we have at that time, until recently, were a pretty toxic drug to give to all patients to prevent this infection, especially when you give it for at least 3 months. So you have long duration. These patients are going to get lots of toxicities, mainly myelosuppression from ganciclovir, oral ganciclovir, or nephrotoxicity from foscarnet. If using foscarnet, they're going to get kidney dysfunction. So we found out that it's not a strategy that we can really follow because we're putting at risk, patient at risk for all these side effects and other collateral damage. For the past probably 15 years, we moved away from prophylaxis to what we call preemptive therapy. And what I mean by preemptive therapy is you have a sensitive test that you do it routinely, either once a week or twice a week during the high-risk period, in patients even without symptoms. And usually, patients with CMV reactivation, they have no symptoms in stem cell transplant, different than solid organ. Solid organ transplant, they may get what we call CMV syndrome, a little bit of fever, maybe leukopenia and malaise, but we don't usually see it in stem cell transplant because they have other side effects or adverse event from the conditioning regimen and from all the complications after transplant. So no symptom, they get tested once a week or twice a week up to day 100. As soon as you have a positive test, for CMV, and usually it's by PCR, depends on the threshold, depends on the institution. Every institution, they have their own threshold. You start treatment for short duration. So what we're doing is try to decrease the amount of exposure to antiviral, but at the same time treating for short duration and decreasing the incidence of progression to end organ disease. Did it work? Yes, it worked. Meaning the incidence of CMV disease went down to less than 6%. It used to be between 20%, sometimes much higher in high-risk patient population. But with this strategy, we decreased the amount of CMV disease. But still, we're still treating patients with toxic drugs, put them at risk for toxicities. At the same time, and I think this is my next, or the other slide I'm going to show you, there is a problem allowing the virus to reactivate, even a little bit. It's not good for our patient. And I will show you new data published around 1 year ago. So preemptive therapy, that's what everyone has been doing until end of 2017 or early 2018. Now there's a paradigm shift. Now most of the centers, at least in the US, we're using a new drug to prevent CMV, and I will talk about it at the end. So things are changing in the CMV world. So this is one of the studies. There's another one also, but this is the biggest study from CIBMTR with the International Bone Marrow Transplant Registry, that most of the, if not all, cancer centers or transplant centers in the US internationally are part of it. They feed data to this database. They looked at more than 9,000 transplant patients who got transplanted for leukemia, either AML, ALL, MDS, or CML. And the question, they had two questions. First, is allowing a little bit of viremia is going to affect mortality or not on this patient? Meaning, patient, you're doing preemptive therapy, you're checking their CMV, and they're reactivating a little bit. What the impact on non-relapse mortality? Actually, what they found that any level of viremia increase non-relapse mortality when you compare to no viremia. So having viremia by itself put patient at disadvantage for survival after transplant. It's not something new. Actually, Fred Hodge from Seattle, Michael Bach, showed a long time ago that even having antibody against CMV, meaning being exposed to CMV, IgG positive, seropositive recipients, increase their mortality, all-cause mortality, or non-relapse mortality. These patients did not die from CMV disease. Very rare to die from CMV disease, not that common, but they died from the indirect effect of CMV infection. So this has confirmed our doubt, our hypothesis from before that any level of viremia is not good. It can increase mortality. But the other question they answered also from this database, and there's few studies in the past showing that a little bit of viremia decrease leukemia relapse, mainly either ALL or AML. So this was some idea out there showing that maybe good to have a little bit of viremia. But this cohort showed no impact on relapse. So across the board, a little bit of viremia or good CMV viremia is not good for our patient. What can we do to prevent this from happening? Before I talk about new drugs and what's going on in the field of CMV treatment-wise, let me talk about how can we optimize the strategies to prevent this infection in our patient. Can we understand better how our immune system, our patient immune system is working to control this infection? Can we combine viral load with immunoassay or looking at CMV-specific T cell? Would this help us in managing this patient in the future? So this is our first study that we did around a few years ago, where we followed around 66 patients after transplant. We got their blood on a monthly basis up to day 100. And we are interested to see if these patients had good CMV T cell responses during transplant, would they be protected from CMV reactivation? So it was kind of an observational study that we did, and we did an ELISpot assay. I'm going to talk a little bit about it here. It's a ELISpot platform where you take patient blood, you isolate the PBMCs, standardize it in 4 wells, and you expose these cells, T cells, to two peptide of CMV, i.e. 1 and PP65. If these T cells were primed to CMV, they're gonna start secreting gamma interferon. If you have enough CMV-specific T cell, and you measure interferon. So if you have good level of interferon, you're gonna have a good CMV T cell available for the patient. So this is kind of, in a nutshell, how the ELISpot works. What we found out actually in this cohort that some patients reactivated, some did not. 1/3 reactivated, the other did not. Same kind of characteristic, except the one who reactivated were at higher risk. They had higher risk of transplant than the one who did not reactivate. But what's important is what we found that patient with good T cell, CMV-specific T cell, before reactivation, they were protected from CMV reactivation. So we could tell with one test who were reactivated or not. So they were pretty much reactivated, so high negative predicted value. But not all patients with no CMV-specific T cells reactivated, but most of them, but not all of them. And as you see here, this is the, I don't know if you can see the, let me show it to you here. High risk on the blue. So the one with high response, they had a good, less CMV reactivation, except only 2 patients reactivated. But these 2 patients with high T cell, they were on high-dose steroids for GVHD. So anytime you have a high-dose steroid or GVHD, this test is not gonna work, because there's different pathway that cannot control CMV. So after we did the first study, we said, okay, is it only this kind of result only related to our single center experience? So we want to validate our result with multi-centers. So we had 14 sites in the US who contributed to 239 patients, where we follow patients on a weekly, on every 2 weeks with CMV T-spot assay. It was also an observational trial to see if this ELISpot gonna predict CMV reactivation. What we found actually, the same thing, that these patients, around 80 reactivated, 159 did not reactivate, same kind of characteristic, except a little bit more higher risk on the patient who reactivated. Same kind of graph. The one with high T cell responses to CMV, they had lower level of reactivation, and most of these patients were on high-dose steroid, versus the one with low response, and you see more than 50% reactivated their CMV. So with one test, we can predict if they're not on high-dose steroid, which stem cell transplant recipient will reactivate their CMV. So this is all observation, so validate our data. So at the end we said, okay, can we intervene? So these tests will be useful if we can intervene. So we looked at low level of CMV viremia in our patient, because now with the PCR, you get all these numbers like 100, 137 IU per ml, or maybe 200. Would you treat or you would not treat? Because there's no way at that time to predict who will progress or who need to be treated. So we said, okay, let's try to see if this ELISpot assay will help us to predict who will progress and need to be treated. So we enrolled 55 patients. This data was just published 2 weeks ago in GID, and we follow them up to 60 days from the first episode of low reactivation. And as you see here, some patients progressed to high level of viral load and they got treated, and almost 50% did not, and they were not treated. So we prevented therapy in 50% of the time based on one test. And quickly, what we showed also, patients with a high T-cell response did not progress, and they didn't need to be treated, except 2 patients here, and the same message. They were on steroid, high-dose steroid. But all the rest reactivated and progressed to a high level, and they were treated because they had very low T-cell response for CMV at that time. So now we are intervening. If you have patients with low level of reactivation and you want to treat or not, if you order this test, could be the ELISpot or other or intracellular cytokine assays, it can help you to determine treatment or no treatment. So you can, because I'm sure as of today we're still over-treating these patients. because we don't know what to do with this low level of reactivation. And this is dynamics over time as well. Anytime you have increase in CMV T cell response, decrease in progression. And the other way around. Decrease in T cell response, increase in CMV viral load and in treatment. So we found strong association between low CMV-specific T cells and progression to clinically significant CMV infection. So this is some kind of the immunoassay that you're going to probably hear more and more about. And not only in stem cell transplant, the same kind of studies were done in solid organ transplant, probably a little bit more studies than in the stem cell transplant. And hopefully, in the future, the new guidelines will have good data, try to guide people how to incorporate these tests if it's available for you in managing this patient. Let's talk about drugs now. These are the old drugs, or the commercially available drug that we've been using for years to either treat or try to prevent CMV infection in immunocompromised patients. Acyclovir, the first one, is a very useful drug for herpes simplex, for varicella zoster, or prevention. All our patients should be on acyclovir or valacyclovir for that, but also it's been used in high dose to prevent CMV reactivation, mainly in cord, blood transplant, or haploidentical versus kidney transplant. There's some data showing it worked, but you need to use very high dose. When I say high dose, it could be 2 grams every 8 hours. We tried it in our institution, didn't work. Patient could not tolerate this high dose. So we had to stop this strategy. But I know some centers are still doing it, or they're doing 1 gram every 8 hours, a little bit lower. Again, acyclovir came to the market, and been used for either prevention or mainly for preemptive therapy in this patient. It's effective, but the problem is myelosuppression. Foscarnet as well, same thing, it works, but nephrotoxicity. Cidovovir, our experience with cidovovir for CMV is not great, even for treatment. If you're going to compare it to Foscarnet or ganciclovir, it's probably suboptimal to use cidovovir. We use it sometimes when patient has resistant CMV infection, sometimes in combination or nothing else is working, I may go with cidovovir. But I will leave it as the 3rd or 4th line of therapy because it is very nephrotoxic, myelosuppressive, but at the same time doesn't work that well. When we use it, doesn't really impact much the CMV viral load or help with the CMV disease. Valacyclovir, the prodrug of acyclovir, is better tolerated than acyclovir, where you have to use very high dose to prevent CMV. So there's lots of shortcomings with the commercially available drugs, and mainly because of toxicities. So we knew for the past 20 years, we needed new drug, new strategy to prevent or to treat CMV infection. The good news, now we have some new drug we've been testing for the past 15 years. We were not successful with many, but at the end, we've been successful with few drugs that are gonna change the way we approach CMV in transplant patients, and not only in stem cell, but also in solid organ transplant. This is one of the review that we just going to be published soon. So looking at letermovir, but we looked at other drugs as well. And this is the new drug that I'm going to cover quickly. Brincidovir under development, maribavir, and letermovir. Different mechanism of action that I will talk about specifically for each drug. But this is the good news when I say different mechanisms of action, because the cross-resistance, it's not going to happen when you have different mechanisms of action, except probably for brincidovir, because it is the prodrug of cidovovir, or you add the lipid chain to cidovovir, and you get the brinci, or brincidovir. Not all the drugs are the same or cover the viruses, herpes viruses the same, or double-stranded DNA the same. And something that's very important to remember, especially for clinicians taking care of immunocompromised patients, you need to be aware for each antiviral available under development, which virus will cover. And this is a new review that we're going to publish soon in antiviral research, where we looked at all published data on IC50 for these viruses. double-stranded DNA viruses. Brincidovir, probably the broader spectrum of activity against all double-stranded DNA viruses. Cidovir is the same, except for few, but if you look at foscarnet, usually it is a broad-spectrum antiviral, but the problem with foscarnet, the IC50 is pretty high. It's not low. You need higher dose to overcome the IC50 of each viruses, okay? And this is the issue with foscarnet. Letermovir, which I will talk about it later, it covers only CMV. Doesn't cover herpes simplex or varicella zoster. Something to keep in mind, if you're using letermovir, you have to still use valacyclovir or acyclovir to prevent other herpes simplex, other herpes viruses. Maribavir, it works against CMV mainly, and maybe EBV in vitro. There's no in vivo data, but no other viruses. So it's important to know the difference between all these, and this is acyclovir and artesunate, the difference between all this, in order when you have a strategy to prevent or treat, you want to know which antiviral to use in this patient population. Let's talk first about brincidovir. Brincidovir, it's a nucleoside analog, prodrug of cidovir. It has this lipid chain attached to cidovir, which make it, can take it in oral format. Also, now they're developing IV, intravenous, but it will actually mitigate the toxicity from cidovir, and it has better penetration into the cells. It's a broad spectrum of activities. Unfortunately, we did phase 2 and phase 3 trial trying to test brincidovir as a prevention for CMV infection after stem cell transplant. Phase 2 trial worked very nicely. Phase 3 trial did not work, and I will tell you why. And actually, this was published recently. We enrolled more than 400 patients, comparing brincidovir oral, 100 milligram twice a week. It's long, to use it only twice a week, versus placebo, and you use it up to 14 weeks from transplant. But you measure the primary endpoint at week 24. Now, all the phase 3 trial, after many years discussion with the FDA, we moved away from primary endpoint of CMV disease, because CMV disease is becoming very low incidence. Now you need thousands of patients for this kind of primary endpoint, because we know with preemptive therapy we can control it. So what we convinced the FDA of the past many years, based on many data published, that clinically significant reactivation necessitating IV therapy could be a good primary endpoint. So we're not relying on end organ disease, but we're looking at reactivation plus treatment as a primary endpoint. But you measure it at week 24, meaning you stop the drug at week 14, which is the highest risk period, up to day 100, but you want to see if the effect carry over to week 24. What happened here, up to week 14, it worked. There's some difference, but you see on brincidovir, the impact is getting worse and worse, and up to week 24, almost like placebo. So it was a negative trial. It did not work. And I will tell you why it did not work. It's still a good drug with good antiviral effect. The problem was this drug has a major toxicity, which is GI toxicity. It can cause severe diarrhea. And guess what? After transplant, when patients have diarrhea, what you have to rule out mainly? Graft versus host disease, which is the worst outcome. And when our patient on brincidovir got diarrhea, they got scoped, colonoscopy, and look, they found they had more GVHD than the placebo. It did not make sense, but that's what we found out. So probably the impact on the mucosa of the GI tract of brinci, it can mimic GVHD. When you diagnose GI GVHD and you're not sure, you blast them with steroids. And patients on brincidovir, they got 8 times more steroid than the placebo because they had diarrhea, we are suspecting GVHD, they got more serious. They were much more immunosuppressed than the placebo, and more died than the placebo because of the toxicity. It wasn't because of the buoyancy, but the toxicity from brincidofovir. And they were more. So unfortunately, it was a negative trial. It didn't work out. And what they're gonna do, they're gonna pursue buoyancy because we know we need this broad spectrum antiviral, not only for CMV. It's gonna be tested mainly for adenovirus. And it's ongoing trials for pediatric. We're gonna start the adult soon in our institution for also adenovirus viremia in adult patient as well after transplant in intravenous form. So the intravenous form would bypass the GI tract and will have, hopefully, less GI toxicities. Because this is the main issue with brincidofovir. Let's move on to maribavir, another drug also. This was probably the first trial that I worked on for CMV prophylaxis more than 10 years ago now, 12 years ago or 14 years ago, where we did the phase 2 trial, and it worked, actually. When we moved to the phase 3 trial, I'm going to show you the result, unfortunately. So we've been testing multiple drugs for the past 15 years, and we were not lucky until recently. Maribavir, new class of antiviral, benzimidazole, orally bioavailable. It's only in oral form, no intravenous form, and inhibit UL97 protein kinase, and this is for the virus. So different mechanism of action, and no cross-resistant with either ganciclovir or maybe for ganciclovir, but not for at least foscarnet and cidofovir, because there's no cross-resistant with UL54. It worked against only CMV and in vitro EBV as well. So in the phase 3 trial, in the maribavir, also patients were randomized to either maribavir or placebo, 2-to-1 randomization, with the primary endpoint at that time was CMV disease. This is before the time when the FDA agreed to change the primary endpoint to clinically significant CMV infection, unfortunately. And this drug in the phase 3 trial did not work. No difference in CMV disease when you compare placebo to maribavir. But keep in mind, when I say placebo, what do I mean? It's preemptive therapy. And we know when you compare preemptive to prophylaxis, same impact on CMV disease, because with preemptive therapy, you decrease the amount of CMV disease. So it wasn't that surprising. But what was surprising is all-cause mortality was the same for both, but it did not prevent CMV reactivation at the same time. So the same amount of reactivation occurred while on maribavir or placebo. And the reason, I think, mainly the dose that was picked for this study, it was 200 twice a day, 200 twice a day, which was a lower dose. So multiple problems with the design, which make it a negative trial. The good news, they didn't give up on maribavir. It's gonna be developed, and actually it's been developed now for treatment of resistant CMV or refractory CMV infection. This data just published this week in BBMT, looking at stem cell transplants, solid organ transplant, with the refractory or resistant CMV infection, who got maribavir at different dosage. And they found that for all those, around 67% responded to maribavir. And I'm talking about patients who were not responding to standard of care, like ganciclovir, foscarnet, and they had refractory CMV, and now we have a drug that it worked in 2/3 of the time in this patient population. So they tested different dosage. And the problem, the only issue with this drug, some had recurrence while on treatment, or even later on, and also had high incidence of toxicity, which is dysgeusia, meaning change in the taste. You have taste disturbances. I could tell when I enroll patients on these trials that they are getting maribavir, because they will tell you they have metallic taste. The taste disturbance change. It's pretty common in the high dose, which is the 400 twice a day. As I mentioned earlier, the good news, new company took this drug and they developing it for, we have 2 trials ongoing, one for refractory resistant phase 3 trial. It's enrolling pretty good, and using 400 twice a day instead of the lower dose. And the other trial, the preemptive therapy, meaning any patient with CMV reactivation, they will be randomized to maribavir or valganciclovir, up to 6 weeks of treatment. So this one is not enrolling much for different reasons, but this one, at least more than 50% of the enrollment is done. Hopefully by next year, you will see some preliminary data on that, because we need a drug for refractory and resistant CMV. And keep in mind, before I move on, resistant CMV infection is not common, but refractory is common. It's pretty common. And what I mean by refractory is patients who have CMV reactivation, you treat with standard of care, and they still have climbing viral load, or they're progressing even on treatment. You test for resistance, there's no mutations. They have no resistant virus, but still they progress while on treatment, and all has to do probably with the host immune system. With their T-cell therapy, my hypothesis is antiviral by itself does not work unless you have a good CMV T cells, at least CTL, to kill the virus as well, in addition to antiviral. So refractory, it is common, and we see it quite often, unfortunately. My last few slides on letermovir. And this is the first drug over the past 20 years who got approved in November 2017 for CMV prophylaxis in adult stem cell transplant recipients who are CMV seropositive. So all adult CMV seropositive after allogenic hematopoietic stem cell transplant, they can get letermovir to prevent CMV infection. Different mechanism of action. It acts on the terminus complex of CMV. You have the DNA elongation, but at the end, before you cut the DNA and put them in capsid, it will inhibit the terminus complex, which is the UL56 and UL89. So there's no cross-resistance with other antiviral. We did the phase 2 trial, mainly a few centers, and we were the main centers to test it in phase 2 trial. Randomized patient, double-blind, placebo-controlled, 132 allo-HCT. And it was dose-ranging trial to see what the dose that worked best in this patient. And the primary endpoint was clinically significant CMV or viral load suppression. And what we found is that patient on letermovir 240 milligram, it prevented much more CMV reactivation than placebo that you see here. More patients reactivate on placebo than the 240. Interestingly, in this letermovir on the 240 milligram, if you only look at virological failures only, it was 0 on 240 milligram versus placebo were around 38%. So it worked nicely in the phase 2 trial. It moved to a phase 3 trial, which was published in 2017 as also prophylaxis for clinically significant CMV infection after stem cell transplant. More patients were enrolled, around 570, 2-to-1 randomization. Same primary endpoint. You give them the study drugs up to week 14, you stop the study drug, and you want to see if it carry over to week 24, and looking at the primary endpoint at week 24, which was clinically significant CMV infection, meaning CMV reactivation above certain threshold, and you initiate treatment for CMV. This is the primary endpoint. And what we found, it worked very nicely. When you look at the primary endpoint, only 37% reactivated on letermovir versus 60%. But when you look only at clinical significant infection, because in the primary endpoint you add also discontinuation of the drug and other type of failures or loss for follow-up. But when you look only at CMV infection, it was around 17% versus 42% on placebo. So it worked very nicely. And CMV disease was the same, but the icing on the cake from this trial, which validated different cohort, it had impact on mortality. All-cause mortality at week 24, it was certainly significant. It was an exploratory endpoint, but we showed that the impact also, if you prevent any reactivation, you have lower mortality, at least at week 24. At week 48, it's still not significant, but they were still numerically lower on letermovir than not. So this is letermovir at week 14. It worked nicely, and week 24, and this is the mortality data. So 5 versus 7.1% versus 10 and 15 or 16% at week 48. It plotted the significance at week 48, and it has to do probably with the power. It was not powered enough to look at mortality. But this confirmed our initial hypothesis and the other cohorts data showing that all-cause mortality could be affected by CMV viremia. Side effect, not much. We couldn't tell if our patients were on letermovir versus placebo. And it was a little bit different side effect between the two arms, a little bit more headache, peripheral edema maybe on the letermovir, also a little bit more tachycardia and AFib, but it didn't lead to discontinuation of the drug. And the placebo, they had other type of risk of adverse event before. So this approval in 2017 led to a change of our strategy in our immunocompromised patient. Now, many centers are start picking up letermovir. We start using letermovir in March 2018 at MD Anderson, and we use it for every recipient positive, starting at day 7 from transplant and up to day 100, like it's indicated. And we looked at our data recently. Stay tuned. Hopefully by next year we get it published. It affected CMV reactivation. We're seeing much less reactivation than before. And also there was a trend to lower mortality. So in real life experience, we're seeing almost the same thing like we saw in the phase 3 trial. So I think they're going to have a paradigm shift with letermovir, where we're going to now move away from preemptive therapy to prophylaxis by next year or more. And hopefully, I don't think you have it already here in Brazil, but I'm sure, in Europe, few countries already have it, Japan probably, and many other areas of the world. I would say it's a game changer. It is an expensive drug, but there's a good cost effectiveness in this molecule because you're preventing admission for preemptive therapy. And we have data on cost, actually, stay tuned, going to be published soon, where we're going to save much more by using the letermovir than treating preemptively all these infections. So in conclusion, CMV serostatus and reactivation remain important variable affecting transplant outcome. And that's what we worry about. At the end, what we worry about is all about mortality. And also morbidity, but mortality is our ultimate outcome. And we showed with some of the drug that it can affect outcome. New antiviral are under development. We're successful with letermovir. Hopefully, maribavir and brincidovir come to the market. This also will help us to take care of our patient with different viral infection. And also maybe immune monitoring in the future will help us manage this patient and tell us when to stop maybe prophylaxis, when to start treatment for low CMV infection in the stem cell transplant, but also in solid organ transplant population. Hopefully will have an impact at the end on mortality, because this is our main goal when we prevent or treat these kind of infection. And this is my last slide. Thank you.